And then, yeah, if I can start webinar now.
Yeah, let's start the webinar.
All
Thank
right,
you.
opening it up now.
Hello, everyone. Thanks for joining. Welcome. We'll just give about a half minute here to let more people sign on. Yeah, I still see a few more people entering, so we'll get started in just a second here. Well, welcome, everyone. I'm so glad you made some time to be part of our UCSF Global Oral Health Symposium for 2026. My name is Ben Chaffee. I am the director of the program in Global Oral Health at the UCSF School of Dentistry, and I'm a professor of oral epidemiology and dental public health. We have been hosting the symposium for 15 years, going back to 2011. And this symposium always reminds me of mentor and friend, the late John Greenspan. John was our inaugural Associate Dean for Global Oral Health at our school, a longtime professor here. And this symposium was really part of his vision to bring together academics, health professionals, people working on the ground to advance oral health for everyone. Today, we do this on a live online platform. It really makes it a truly global event. We can reach people in many more places, not only the people who are here right now live, but we know these recordings will get hundreds of views in the years ahead. So thank you for joining us, whether it's here today or you're watching this later. I do think it's important that we acknowledge when we talk about global health what a challenging time it is right now for global health, and that includes oral health. I don't want to be dismissive of the seriousness of the threats that we're facing, but I think we have some reasons to be optimistic. One notable example, uh, just how encouraging it is to see oral health take a place on the global stage, as what we've seen with the World Health Organization and their global strategy and action plan for oral health, setting out a vision where universal health coverage includes oral health for everybody. That prominent inclusion of oral diseases in the December 2025 declaration from the World Health Organization on non-communicable diseases. This places oral health at the table with attention, with recognition, with prioritization, really saying that this is a critical part of an overall global strategy to address non-communicable diseases. That kind of recognition and political will and declarations are, of course, important. Funding is another challenge. Um, Funding for whether it's research, capacity building, program implementation is always challenging and certainly no easier today. But there's some bright spots. One of our speakers today is supported through the U.S. Fogarty International Program and the National Institute for Dental Craniofacial Research, and you'll soon hear more about her work. And in fact, I should now introduce our speakers. Our keynote presentation today comes from Professor Carol Guarnizo-Herreño from the National University of Colombia. She's a member of the landmark Lancet Commission on Global Oral Health, and she's a leading voice on addressing oral health inequalities. She'll present some of her experiments in implementing what's called the CORE program in Colombia, which is part of an international project to advance oral health across 4 countries and 3 continents. And next, we'll hear from Ximena Concha Melgar, the aforementioned Fogarty and IDCR supported fellow, and that's part of the GLOCAL program here at the University of California. Ximena carries out her research in Peru, and she'll present her perspectives on developing an early childhood caries intervention for remote communities in the Peruvian Amazon. She's an early career scholar and a rising star, and I'm really glad that we can support her work and feature it today. So we hope you enjoy the presentations. I invite you to be part of the conversation. You can share your comments or your questions by using the Q&A function on your Zoom screen. We'll make plenty of time for questions after each talk, and if we want to extend that conversation out at the end, we'll certainly do so. So right now, technology willing, I'd like to share a short pre-recorded message from our Dean of the School of Dentistry, Dr. Michael Reddy.
Greetings and welcome. This is the 15th symposium held as part of our Global Oral Health Program and the 6th year as an online webinar, allowing us to reach audiences around the world. I'm Mike Reddy, Dean of UCSF School of Dentistry. Thank you all for joining us. And a special thanks to our featured speakers from South America. You'll get to hear more about them in a moment. But from what I know about their work, you're in for a treat. Thank you both for joining us today. The symposium has an impressive record of drawing world-renowned speakers and supporting vital research projects in public health, epidemiology, basic sciences, and in the realm of global oral health. Research is central to our mission and is a big part of why the work we do at UCSF has worldwide impact. And this year's theme, Perspectives on Oral Health in South America, is a fascinating and important topic, and I'm thrilled that it's receiving the focus that it deserves. We're grateful to have our talented presenters with us to share their expertise. To all our speakers, thank you for being here. I also want to thank Dr. Ben Chafee for leading our global oral health initiatives at UCSF and for organizing the symposium. Dr. Chafee has once again gathered leaders from across the globe to share their work and inspire us. Let's have today's speakers encourage, energize, and propel you in your own efforts toward achieving positive changes in global oral health. Your work is important now and as it ever has been. And thank you again, Ben, for all that you do, and thank you all for attending.
Thank you, Mike. That was fantastic. And I think we should now turn over to our featured speakers. And Professor Carol, please share your presentation today.
Thank you, Ben. Welcome, everyone. Thank you for joining us. And I will start by really saying a huge thank you to Ben and the whole team at the University of California, San Francisco for the invitation, to Xime as well for being here. And let's start. So I think you can see my presentation now, right? Oops. Okay, so my presentation will be about what you can see here. I will refer to
Still waiting for the
community
slides to come
engagement.
up. Let's see if
Oh,
we can check that
sorry.
again.
I thought you can see them. Sorry, apologies. I thought you were already. Is it okay now?
We
Can
can
you
see
see
them.
them
We just
now?
need to go to full mode. There we go. Perfect.
Perfect. Thank you. Let me know if there is any other issue. Thank you. So, yeah, as I was saying, my presentation would be mainly about community engagement and why we think it's an important foundation for global oral health research, in particular in the context of the core program. And I will give you also some an update of how that has been implemented in the Colombian context. So first, there are no conflicts of interest for me to disclose. And I hope to cover these four main topics during my talk. So first, I will provide a brief Latin American and Colombian context. Then I will talk about the core program, moving on to why community engagement is so important and what it is, and the activities conducted so far in Colombia and our plans to move forward. So let's start with a little bit about the Latin American context. So I think, thank you. One of the features of our region in Latin America, unfortunately, we have many beautiful things, many, nice assets, the people, our culture, But we have to acknowledge something really important for health and for oral health, which is we are one of the most unequal regions in the world. So here you can see a map that the World Bank, put together with data from countries all over the world. So basically what they did is they took data from countries from 20,000, 2000 and over, and they put together this map with the Gini index features for all the countries where data was available. And basically they categorize in 3 groups, so low inequality, moderate in yellow, and high inequality in red. The low inequality group is like in blue. So you see here that the high inequality countries are basically concentrated in 2 regions. One of them is Latin America and the other is Sub-Saharan Africa. So we live in one of the most unequal regions in the world. And within that very unequal region, Colombia is one of the very unequal countries. So let me just show you an example or a figure to illustrate that is this. This figure comes from an OECD graph back for 2022, and basically it shows the number of generations that are needed to go from the group with the 10% lower income to the median income, not the highest income, just the median income in a society for all the OECD countries or different OCDE countries. And you can see here on the far right, Colombia, where 11 generations are needed to go from the 10% lower income to the median income. So we're talking about a country with high inequalities, grounded in all the institutional dynamics in the society with very low social mobility. And that, of course, has huge implications for health inequalities, including oral health. So just as a reminder, Colombia is in the northwestern corner of South America. I don't know why the annotations are still here from the previous slides or from the first slide, but here I think you can see my cursor. So Colombia is up here in the corner of South America, and we have a complex combination in terms of epidemiological profile, a complex combination of chronic and infectious diseases. Also, in terms of health and social issues, we are dealing with the consequences of a very long-lasting internal armed conflict that lasted more than 50 years, problems of access and quality of healthcare, a major role of the informal economy. So about half of the people who work in the informal economy. And as I mentioned before, really staggering socioeconomic inequalities. So that's the Colombian context. And now I'll give you some background information about the CORE program. So as you can see here, CORE stands for Community-Focused Oral Health Research for Equity. And this program, this project is funded by the UK National Institute for Health and Care Research, NIHR, and it's a cross-country collaboration, as Ben mentioned, and the participant countries are Brazil, Colombia, India, Kenya, and the UK. And well, the aims of the program are first to establish these equitable and effective research partnerships across the countries and communities in the 4 countries and 5 with the UK, to assess the pattern, mechanisms, and impacts of oral health inequalities, to determine the influence of commercial determinants on oral health, to assess the economic burden of oral diseases and opportunities for oral health system reforms, and to co-produce and test public health interventions to reduce oral health inequalities and promote oral health. The program, kind of in our initial discussions and also in our conversations with the communities, identify certain values. The first is we really have this as a priority, like to use community-focused approaches. Diversity and inclusion is another value of the program. respect, transparency, and trust, which is very important, particularly when working with the communities, equitable collaboration across the countries, of course, but also across the different participants within the countries. Mutual learning is, if I can say something, the core experience has really been a great opportunity to learn from colleagues, from the other countries, but also to learn a lot from our communities and colleagues that take part in our activities, and capacity building and strengthening, which is one of our components I'll show you. So let me kind of show you the main structure of the program. To kind of meet those aims, which are mainly reduce oral health inequalities and improve access to dental services for disadvantaged communities in the countries, we have 3 work packages. You can see them here. So the first one is really focused on oral health inequalities, the second one on commercial determinants, and the third on oral health system reforms. Those are our 3 work packages. And in addition to those, we have also components, central components. The first one is the one which will be the focus of the talk later on, community engagement and involvement. The second one is training and capacity building. And the third, monitoring, evaluation, and learning. On the left side of the slide, you can see some additional information about our project. So the funding is about 3 million pounds, British pounds. The duration is 4 years. We are now coming to an end of the 3rd year. So officially the program will end in July 2027. And as I said before, it's an equitable partnership with communities and colleagues across the countries, Colombia, Brazil, Kenya, India, and you can see here the names of the country leads in each of the countries. And as I mentioned before, this is funded by the NIHR in the UK. Let me give you more details, more information about the studies within each of the work packages. So the first one, oral health inequalities, has 4 studies. The first one is an analysis of secondary data, basically nationally representative data, to compare socioeconomic inequalities in oral health. So far, we have been able to conduct this analysis with data from 44 countries. So that's ongoing, and the main results of that study will be part of the Lancet Commission report. The second one is a qualitative research with marginalized populations, communities in the countries. We have called this one the Unheard Voices in Oral Health study. The study 1.3. The third one is a simulation modeling, using simulation models to assess different upstream public policy interventions in terms of their impact on population oral health, so averages, and equity impacts. That's a very nice, interesting analysis as well. That's ongoing. And study 1.4 will be our feasibility study, one of our feasibility studies, and the aim is to co-design, co-produce, and test interventions in our communities. That's work package 1, inequalities. Work package 2, focus on commercial determinants, has 3 studies. The first one is it was an analysis of secondary data to analyze the corporate political activities of different sugar and ultra-processed food industries. The second is a qualitative investigation of the sugar and ultra-processed food industry and their influence on oral health in each of the participant countries. Study 2.3 is also moving forward to a modified Delphi process to identify opportunities to mitigate against the sugar industry influences on oral health policy and research agendas. That's work package 2, commercial determinants, and work package 3, which is focused on oral health services and system reform, has again 4 studies. The first one is an analysis on the economic impact of oral diseases. The second one is a community survey on the barriers to service use. The third is a qualitative study to identify opportunities for system reform in the countries. And the fourth is, again, a feasibility study to co-design, co-produce, and test public health interventions to improve access, equitable access to dental care in the countries. So these are the 3 work packages, the studies within each of them. Just wanted to share. And then we have the component, which is our main focus today, the community engagement and involvement. So what is the rationale and the motivation behind having this component as a key part of the core program, as a core component of core? Well, one of the motivations is that for very long time, oral health policy and research really has been dominated by professional perspectives. And we have systematically excluded the views, experiences, perspectives, and expertise from our communities, particularly from the most vulnerable, excluded, and marginalized groups in societies. So I guess all the initiatives that Ben mentioned at the beginning, and particularly our core program, we think that it's definitely time to reframe oral health through meaningful community engagement and share power with the people experiencing oral diseases and their wider communities. So the idea is then to facilitate the co-production of future policies, programs, and services that really can address the community needs and priorities in oral health. So for that reason, community engagement and involvement is a foundational and key element of the core program. But what is community engagement and involvement is? What does that mean? Well, the idea behind this is to level out the power imbalances by creating and enabling supporting environments for participation. So amplifying the voices, agency, and empowerment of diverse and excluded communities. Some of the literature that we reviewed for this was based in very seminal work by a Brazilian academic, Paulo Freire. This is not really recent, it has been discussed for a while, but certainly nowadays in global health discussions, public health and oral health discussions, well, community engagement and involvement is a key element, and it involves different things, right? Like reach out to community, to map resources, structures, to understand better communities, establish community forums, citizen panels, develop trusting and respectful communication, which is key, invest in understanding what communities really need, want, and develop co-production processes with the communities, among other things. So in the core program, the first step in our community engagement and involvement process was to then kind of select the communities, right? Which was very, very challenging. But the idea was to select disadvantaged and marginalized communities to work with throughout the program. So the local teams carefully considered different options, and we also took into account considerations about safety, like really trust or initial approach contacts that we had, networks that we previously had. So the idea was to consider which particular disadvantaged and marginalized communities we should focus upon for our community engagement and involvement plans, but also the research activities. And here, just to clarify, that community can be identified in different ways. It could be like a geographical location, a neighborhood, or groups of people who share different cultural, ethnic, religious, or social identities. So the definition of community could be very wide, very diverse. And the idea was then for local teams to select the priority communities based on their local knowledge of the context, as I say, local dynamics, and the social and ethnic inequalities in oral health. So that was the first step. And it was really a careful process to make sure that we were selecting communities who were, in most need, but also that will allow us to conduct the project. And in Colombia in particular, 2 communities were selected. So we are working with a rural community and an urban one. So the rural is this one, is located in Ocaña, is the name of the region, in Norte de Santander. It's a municipality that borders Venezuela, is here. And the rural area of Ocaña is divided in 18 districts, and Aguas Claras is one of them. Aguas Claras is the community that we are working with. They have different issues, and to be honest, at the beginning, we were not sure if this will be a good fit due to some safety concerns, but at the end we managed and everything has worked well. But I mentioned this because this is a region, an area of the country which has been really badly affected by the internal conflict. So there are presence of different illegal groups, guerrilla, ex-guerrilla groups, and then paramilitary as well, illicit crops of coca that are later used to produce cocaine. So there is a lot of interest in the territory for those reasons, and murders, kidnappings resulting from, as I mentioned before, the internal conflict. So this area is particularly vulnerable because of the internal conflict and all the violence that the communities there have endured. So currently, there is a presence of the Special Justice for Peace. This is, transitional justice after the peace treaty was signed. So things are better, the situation is better, but of course, after a very long internal conflict and with many interests there, of course, it's not like you sign the peace treaty, next day everything is perfect. No, this is a long process, and sometimes the conflict kind of reemerges. So we are all the time assessing the situation. This is the rural community, and the urban community is this one, is in Bogota, is in the Usme area. So it's part of the Bogota's localities. This locality, Usme, has 7 different areas, and Danubio is one of them. It's the Blue Danube, so Danubio Azul, the Blue Danube, and this is the neighborhood where we are working. And well, again, it's an area that is vulnerable due to various reasons, like migration. There is a high presence of recent migration, particularly from Venezuela, high crime rates, micro trafficking of illicit substances, increase in murders in recent months. So that makes the community vulnerable. Again, we are constantly assessing the situation and really being very careful in planning our activities. But the community is just amazing, it's great. And yeah, they have been super supportive. So now I'll share with you guys the community engagement and involvement activities, strategies that we have developed so far. And they are mainly the community mapping, the community forums, link workers, and the outreach activities, including performing arts events. You can see here on the right side some photos from communities in the 4 participant countries, but from now on, I will focus on the activities in Colombia. So the first step, will be the second really, after selecting the communities, was the community mapping and development of the community engagement and involvement action plans. So the community mapping exercise was aimed to identify, to understand better the participant communities. So we kind of use a mixed methods approach, like we visited some websites, official statistics were taken from there, but also we talked to people, we did different meetings, visit to the communities to really get to know them in terms of the demographics, identifying community leaders and groups, facilities, healthcare services, civil society organizations working in the community, public capital, neighborhood resources, and so on. I just noticed, sorry, apologies, my spelling is for British English, so I know probably most of the attendees are American or based in the US, so sorry, you will notice this is British spelling. I noticed with the neighborhood one now. So findings of that mapping exercise were then used to develop the action plans. And we did it with a participatory approach. So all the time we were discussing with community members and within our groups the plan of the activities, the organizations to work with, the methods and tools for engagement. And we keep on kind of, updating and developing those action plans. So they are live, right? They were not set at the beginning on stone. No, they are live, and we keep updating them. And also a community engagement and involvement coordinator was appointed in each country to lead and develop the community engagement plans and activities. So you will see here some images from the community mapping in Colombia. This in particular, we meet with different groups. This is an example, the meeting with teachers of the Aguas Claras school, where, different opportunities, capacities, needs for the communities were discussed, barriers to achieve a good oral health from the perspective of the school. And just a quote here, many of the parents are farmers and don't have time to take their children to the dentist. And you can see on the lower part, sticky notes on terms of the barriers, education, capacities, needs of the Aguas Claras communities. And on the right side, you see the teachers doing this part of these activities, discussions for the community mapping. Also in Aguas Claras, the community mapping involved older adults, school children, and women. This image here is the meetings, the activities with the school children, where the children were asked to identify again their experiences with oral health, how they see barriers to dental care services, what oral health means to them, and so on. And basically, that was made through drawings. So this is just a quote from one of them: "Nobody takes care of me, I take care of myself." And on the right side here, this is from the meeting with the women, the mothers, and one of the quotes from them: "We women have to do many things to take care of our families." So some gender role issues there appear as well, and how they relate to oral health. That was interesting. And then from the meeting with the Community Action Board, one quote: "We are considered by the national government as a place with security problems, but we do not receive assistance to improve conditions." So we were able to identify quite a wide range of issues related to oral health and really to living conditions. One of them as well, with mothers, with women, was to identify the travel needed from the Aguas Claras community to receive medical, dental, specialized care, considering time and cost. This is my colleague, Luis Alberto, who is part of the team, of the core team in Colombia. And you can see they identify how long will it take them to reach the place where they get dental care, how long, how much that will cost, and so on. So that was also part of the mapping exercise. And as I mentioned before, taking into account all those findings from the mapping, community engagement and involvement action plans were developed with a participatory approach. Another tool of the community engagement and involvement activities is the community forums, another strategy, rather. So the community forums were established in each community, and basically they are local community members who permanently provide input and advice from a community perspective. So all the decisions for the program on community activities, and research conducted in the communities are made collectively between the researchers and the forum members. These community forums are about 5 to 10 people in each community. So, for example, the core team members and forum members discuss at the beginning the principles of this component of the community engagement and involvement component. And based on those discussions, strategies were collectively identified. For example, the arts-based outreach activities. Another strategy is the community link workers. This is a different group of community members, and they act as advocates for the research studies. So the idea is that they support and guide all aspects of the research studies conducted in the communities, and in particular, the idea is that they support the engagement of the most vulnerable and isolated members of their local communities in the planned research. Their link workers are offered training and support to enhance their skills and the confidence to enable them to undertake these roles. So here you see photos from the community link workers in Aguas Claras. And here, for example, on the left side, it is part of the training exercise that was conducted in March this year, because the link workers were the ones collecting information for a study 3.2. I know it's hard to remember. That's the community survey to assess the community experiences with oral health services, the barriers they face, and the ways to improve access to local dental services. So this is part of the training. Also here on the right side, this is part of the training. This is Camila, one of our researchers, a research assistant of the project. And this is, field work, going to the community to collect information. This is also part of that study 3.2. On the left side, you see a map that was made by Camila, one of our researcher assistant in the community. In the team. She's a researcher, an MSc student, actually. And because we didn't have a list of members of the community, there was none. We looked for it, we asked for it to the authorities, the community leaders, there was none. So we didn't have a sampling list or, a sampling framework or anything. So they had to do this nice map here, I think, visiting and kind of going and gathering the information firsthand. So this is also part of the activities they conducted. And then we have the outreach activities, including visual and performing arts events. So this has been really enriching, humbling, and learning opportunity for us. We have done a couple now, but just as an example, a play about oral health as a human right was performed by the community group in Aguas Claras. We prepared that with them, discussed. So throughout the process of preparing and then performing the play, community members discuss ideas about oral health and express an interest in continuing those discussions throughout future arts activities. Last month, I think, or 2 months ago, we did also a puppet show here in the urban community in Bogota. And the whole process has been, as I said, very humbling, very enriching. The photos you can see here from Aguas Claras, from the play. That's a summary of the things we have done so far. As we move forward, the idea is to continue with the ongoing community outreach events and increasingly focus engagement activities on the remaining research studies that are planned as part of the program. So the main focus now, as we enter this stage of the core program, will be our feasibility studies that are aimed to co-produce and test multi-component interventions to promote oral health equity and improve access to dental care services. And a critically important component of those studies will be, of course, the community input. The idea is to co-produce the interventions and the evaluation. And we are learning, of course, but the idea is to use a participatory action research approach. And you see here a photo from the older adults group in the urban community, in the Blue Danubio Sul community here in Bogota. We actually, as part of the core program and as part of our our training activities, capacity building, we do a webinar series. So we do a webinar series within the countries and also a general webinar series of the core program. So just in case you're interested in learning or knowing more about our community engagement and involvement component, we did a webinar back in October last year focused on this component, and you can take a look in our YouTube channel, or our webinars are there, the recordings. And also we are available by email. We have a website and we have a LinkedIn how you say that? I don't use social media, but I don't know what is LinkedIn profile, I guess. If you're interested, please reach out. And I have to acknowledge everything I have shared with you guys and presented here is really a result of a teamwork with all core members. And we just had a meeting of the core program last week in Glasgow in the UK. And this photo is from that meeting. So very fresh. And also I have to acknowledge, of course, the communities, the participant communities who have been so generous and allowed us to learn so much from them. So yeah, just like to acknowledge them all. And this is a photo from the Aguas Claras school. And basically the sentence here says, when you forgive, when the forgiveness is born, the heart is reborn. And because this area has been so affected by the internal conflict, for us as well has been an amazing opportunity to really learn what the internal conflict meant or has meant for many people in these regions. Because when you live in Bogota, like is my case, I was born in Bogota and have lived most of my life here, you don't really realize what the internal armed conflict means for people. So this also has been a great opportunity to better understand the complexities of our countries and our communities. So with that, I will finish, and thank you again for being here, for listening, and happy to answer questions or chat with you. Thank you.
Thank you so much, Carol. That was fantastic. We'll give you a pass on the British spellings.
Thank you.
The talk made up for it. It was fantastic. Thank you. We have a number of comments in the Q&A, so we'll go through those from the audience. Anyone else who would like to add their thoughts, please include them in the Q&A feature. And before we jump in, I'll just start with a much more general question that I think was already captured in a lot of your talk. Just the challenges of getting really authentic community engagement that's really meaningful. I mean, we heard about power imbalances, the challenge of defining exactly what a community is. I mean, what do you see as maybe the top couple of challenges that have to be overcome to make this effective and meaningful?
Yeah, thank you, Ben. Well, I would say, to be honest, the power relationships, as you mentioned, because, these communities are not used to get their voices heard. They are not used to participate in these ways. So sometimes it's challenging to really develop the trust and respect. And that's a slow process for them to get to trust you and to realize that, yeah, it's for sure that they are also equals with you. So that's really challenging. And also, I guess sometimes the expectation management and the ethical issues related with raising awareness of neglected issues. And for example, in some of these communities, there is a lot of dental care unmet needs. And they say, well, you are dentist, so go on, so we need to really be careful with not, creating, expectations that are not going to be met by our program. So I will say those are really, important challenges when you do this type of work. Yeah, more, but I would say those are the main ones. Yeah, thank you.
There's a few comments from the audience that are related to that. So I'll start by saying, what kind of incentives were there for the community engagement work? And how did you make participants feel like you had something to offer to them?
Yeah, well, that's a good question. So, for example, and that also varies across countries, right? You need to be very mindful of the legal issues as well in countries, because, for example, in Brazil, I understand it's not legal to offer incentive for research participants, for example, but for the community engagement and involvement activities, as part of the budget, we pay people, we pay the community link workers, for example, because they actually work for the projects. They are like community researchers. So we are very respectful of their time, and they are kind of working for the project. So there is a budget to pay for their time. And in terms of incentives for the other activities, we assess the needs of the communities and identified, in our case, for example, the most welcome is food. So literally, it could be food vouchers, or these baskets we use in Latin America with food, local food, and we buy those products also locally from the communities. So that's basically it. Yeah, in terms of the incentives, and that was also discussed with the community forum members. So with the communities, what do you think it will be a good thing, a good token of recognition for people's times. And they say basically food is always welcome, and they identify the products as well. And we kind of bought those products from local providers. So yeah.
One more piece about community engagement. Someone raises the comment about cultural humility. And can you talk about that and how it fits into this concept of engagement?
Well, yes, thank you for that. I think, as I mentioned before, it has been a learning process for us all, because even though you say, oh no, be equal with the community, we are not used to that. And we were not taught in dental schools to do that. So to be honest, you are permanently evaluating your own biases, your own preconceptions, and it takes effort, I must say, I must admit, to keep on, revisiting and making sure that we are true to our values and to the principles that we set for these components. So also we reflect a lot after the community activities within the teams, within the countries, and then in our program management group meetings, we reflect. We have field diaries where we try to capture our own feelings, our own thoughts, and then kind of go back to them and reflect to try and be absolutely consistent, or as consistent as possible, to be honest. Yeah.
We've got some great comments in here. We may not be able to get through all of them, but we'll try to do a few more. On a different topic, the political winds are shifting, and in Latin America, more countries are moving towards right-wing governments. And there's a possibility that may happen in Colombia with upcoming elections. What are your thoughts on how this may potentially impact public health and community engaged research? Sometimes those are some of the first programs to be cut under these political ideologies.
Yes, sadly, yes. And we are aware that will happen. Elections are just around the corner for us. Last day of this month will be the first round for presidential elections. And yeah, it's unfortunate. I mean, that could happen. And I guess we need to be creative. And as you mentioned at the beginning, this is happening in the global level, and the local level as well could happen. We need to be creative. We now, if that happens, we need to be aware of the resources that communities already have. They have managed and they have struggled for a long time. So they have non-material resources that we can kind of work together, and also, I guess, raise awareness of the political landscape. I don't think public health is non-political, is neutral. I think it's nothing more political than health and public health. And of course, I think our work is to raise awareness of what politics means for oral health, for general health, and for public health. So yeah, I think we can act at different levels, but as we move forward, need to be creative and need to also create more civil society action and probably advocacy efforts, within the different political contexts that we might face. Yeah.
Another topic, and lots of congratulations and compliments coming in from the audience.
Thank you.
What advice do you have for dentists and early career researchers who want to do similar community-based work, especially those getting their education in other countries but want to contribute with research in their home countries?
Oh, that's a good question. I would say try to link with civil society organizations that already work in those communities, that already work in the countries. Because, for example, we are very fortunate to have within the core program SIWA, which is a very experienced organization of informal female workers in India, and we have learned a lot from them. And also, when we were selecting the communities, we also be mindful that you cannot just go there and just, hey, hello, I want to work with you. And no, this is a slow process, as I said, and it's better if you have already some networks, some links with organizations. So I would say try to make links, get to know people working on the ground with these communities, with the values that you share, because we know there are different types of civil society organizations as well. Unfortunately, not all of them are really guided by equity principles, but many of them are. So try to link with them, try to understand. The best thing we can always do is go live with the communities, experience them, talk to them, and that will change your life, your approaches. But yeah, do it as early as possible, I would say. Yeah.
So another topic. So how do we implement interventions that take into account community engagement, but also make sure that they address commercial determinants, particularly thinking about sugar and the sugar industry? Sugar industry is often operating at a different level than communities, for example, through lobbying and trying to block sugar taxation and other policies. How can you make that part of these interventions to improve oral health?
Yeah, good question, right? I guess the industry strategies are very diverse and goes from very upstream levels in terms of influencing policy decisions, policy making, research agendas, but they also work with the communities. They are very good at doing that. They are very good at advertising. I remember, I think probably in Mexico is very clear the example where very poor communities, they didn't have access to water, tap water, drinkable water, but Coca-Cola was there, always there. So communities are really influenced by the commercial determinants, and you can openly discuss this with them, see how they read the messages from the industries. Here, for example, we are very interested in analyzing with our communities the food front labeling for the ultra-processed foods, if they really understand those messages, if it's working for these vulnerable communities or not, and also the sugar tax. So we are trying to see how those measures really are perceived, and if they have an impact, particularly in these vulnerable communities. So I guess you can take an approach with you can work with the communities on commercial determinants and understand how the industries have different strategies to work at the very high level of policymakers, but also with the communities, and present themselves actually sometimes as the saviors, they are doing, charitable stuff. I say this openly because I've seen it firsthand, and you can talk to communities about this, and it's very enriching. So yeah.
Let's do one more question here. So
Sure.
there's a lot of different research methodologies that go under different labels: community-based participatory research, community engaged research, and they can have different levels of community engagement. In the US, there are some tools to evaluate community engaged research. And do you have some recommendations for tools, methods that assess the level of engagement and effectiveness that are appropriate for different cultures and different languages?
Well, good question. And I would say now we are working with NIHR guidelines because, of course, we are funded by them. But besides that, I think their guidelines are very good in terms of assessing that. I would say also there is now a growing body of evidence in global health literature about this. So WHO guidelines are good, NIHR, I would say as well, and all the participatory action research, literature is very good. We came across some frameworks to assess that recently. One of them is the ACE framework, like ACE framework. That's a good one. And another one has a funny name, the Prosecco. It's a Prosecco framework as well. So you might want to take a look at those. Those might be helpful depending on the situation, but I think, they might work as well. Those are frameworks to assess the community engagement and involvement component in research and community programs. So, yeah.
Well, wonderful. don't go far. We'll move on to the next talk, but if anyone has additional questions and comments, and there are a couple we didn't get to, please feel free to add them to the Q&A. Carol, if you're willing to do it, you can type responses, and they'll be posted to the rest of the community. I think we'll also have a little bit of time at the end if we want to pick up this conversation again.
Great,
one comment I'll
thank
make too, a question came in, will the recording be available? Yes, absolutely. This is being recorded. We'll post that online and we'll send a link to everyone who registered. So if you're tuned in today, you'll get an email once that is available and you can share that in your networks. But with that, we'll move on to our next presenter. So Ximena, go ahead and please take it away.
Okay, hello everyone.
Well, the slides were just there and they disappeared, so.
Disappear, okay.
There we go.
You can hear?
Yep.
And you can see, okay. Well, hello everyone. First, I would like to thank Dr. Ben for the opportunity to be part of this symposium. And it's a pleasure to share this space with Carol. And it's especially meaningful for me as I am a 2026-2027 Global Fellow of the University of California, Global Health Institute. So in this presentation, I will share my fellowship research plan, which aims to lay the groundwork for designing an early childhood caries prevention strategy in the Peruvian Amazon. At its core, this work is about moving toward community-based action through context-sensitive, interdisciplinary, and intersectoral approaches that align with today's global oral health priorities. And let me start with some brief context. Peru is the third largest country in South America and has three major natural regions: the coast, the Andes, and the Amazon. These regions are very different geographically and socially, which is important for understanding health inequalities in the country. Peru has remarkable cultural wealth with ancient traditions, world-renowned gastronomy, and vast natural reserves. It is one of the world's mega diverse countries, and here we can see the Amazon River, that is the largest in the world by volume. And actually the population is around 34 million, but 59% live in the coast, around 27% in the Andes, and the remaining 14 live in the Amazon. The official language is Spanish. However, there are 48 native languages from 55 indigenous peoples, located mainly in the Amazon. About monetary poverty affects about a quarter of the population of the coast and around 1/3 in the Andes and the Amazon, with rural areas being the most affected. But when we look at multidimensional poverty beyond the income alone, the Amazon stands out even more due to major deprivation in health, education, basic services, physical environment, and also social participation. In the Peruvian Amazon, many communities live in conditions of profound geographic isolation and are often reachable only by river. Hygienic conditions are very poor. Access to running water, electricity, and sanitation is often lacking, and major barriers to timely and quality healthcare remain. So at the global level, who is pushing countries to move beyond treatment-centered dentistry and toward integrated public health action? This agenda emphasizes universal health coverage, equity, primary care integration, health promotion and prevention, life course approaches, and shared social and behavioral determinants. And these priorities are closely aligned with global oral health, because they place equity and context at the center. So we must ask where oral health needs are greatest, where barriers are deepest, and where prevention has been least integrated. And in Peru, that led us to the Amazon. And there we see many people living with complete tooth loss or edentulism, that is the most severe functional outcome of the oral disease continuum, and the end stage of a long progression of preventable and neglected oral diseases across the life course. And for more than 3 decades, Latin America, and especially Peru and Bolivia, has remained among the countries with the highest age standardized prevalence of edentulism worldwide. But the pathway to tooth loss begins much earlier with early childhood caries. And caries is a chronic cumulative life course disease. If effective prevention is not introduced early, and if health behaviors and living conditions do not improve, its progression becomes highly predictable over time. And early childhood caries, that is painful, development harming, and long overlooked, is the most common childhood condition in Peru and in the world. But in Peru, it's about 76% of children aged 3 to 5 years that have experienced caries. And the first 1,000 days of life, that is from pregnancy to age 2, are a strategic window for early prevention. This is a critical period of high developmental plasticity, when environmental influences can shape the risk of caries and other future non-communicable diseases, and when health habits and eating patterns begin to form. And it's a key opportunity to integrate oral health into maternal child health, primary care, and community-based action. Caries is a behavioral, biofilm, and sugar-dependent disease that shares determinants with other childhood conditions. Its prevention should be integrated into early life practices related to feeding, to caregiving, to access to care, and supportive environments. And this called for an interdisciplinary and intersectoral approach addressing key risk factors early, that are sugar, fluoride, oral hygiene, and care seeking. And this may generate benefits beyond the mouth, because caries is an early marker of unhealthy foods environments and is linked to future multimorbidity. So where can this happen? In a real world underserved settings. And in the Peruvian Amazon, there is an existing community-based maternal and child health platform called Mamás del Río, or Mothers of the River. At its core are community health workers selected in community assemblies who visit pregnant women and newborns at home to deliver health-promoting and disease-preventing messages. And what makes the program innovative is its use of digital technology. The community health workers use tablets with an app containing educational images and videos co-created with the communities, while also collecting health information to support local decision-making and also to coordination with primary healthcare services. Mamás del Río is an award-winning social innovation in health, recognized by the Pan American Health Organization, WHO. The program evaluation has shown that it improves essential newborn care indicators and increases institutional birth, even during the COVID-19 pandemic. This helping to reduce preventable deaths. Because of its positive impact, Mamás del Río, who was expanded to the Peru and Colombia border as Mamás de la Frontera, or Mothers of the Border, with support from the Ministries of Foreign Affairs of Peru and Colombia and the Inter-American Development Bank. And in this new phase, the community health workers not only support pregnant women and the newborns, but also follow children through their first year of life, while promoting vaccination, anemia prevention, non-violence caregiving, and also family planning and the reduction of violence against women. And yet, one key element was still missing from this early childhood development platform, that is oral health. With support from the World Dental Development Fund of the FDI World Dental Federation, I was able to integrate the promotion of essential preventive care for early childhood caries into Mamás de la Frontera between 2024 and 2025. So I trained community health workers in one district of the Peruvian region on the prevention of early childhood caries, highlighting its importance for oral health and for a healthy child growth and development. We also conducted many hands-on demonstration workshops, brought together primary healthcare personnel from the area to provide them with the same training. And the participants included staff from oral health, from nutrition, and child care services. I visited the communities with the community's health workers to support them in bringing this information to families, and importantly, to help them observe and to better understand the oral health situation of children under 6 in their own communities. And that's very important because I also succeeded in engaging the dentists responsible for these communities, together with personnel from the Ministry of Development and Social Inclusion, who helped bring outreach services to rural and geographically dispersed populations. We can see here the dentist with me and the families. He's here. And we can already see how community health workers work directly with the community. And this close collaboration with community health workers, families, and local primary health care staff enable the co-creation of a digital resource called 12 Steps for a Healthy Start in Life, from birth to age 2. It was designed as a practical tool to support holistic child health and development during the first 1,000 days, incorporating oral health as part of an essential care package. And this process helped align messages and practices to promote culturally relevant and cost-effective measures through health visits, the home visits, and community counseling. And the 12 Steps resource was inspired by UNICEF Brazil's 10 Steps to Healthy Eating and Healthy Habits, and that is an existing model that already integrates oral health into early life health promotion. And these are some examples of contextualized guidance provided by our digital resource. We made a cardboard hand fan summarizing the 12 steps because we want to keep the messages visible in daily life in a format that is practical and useful in the local hot weather setting. That can also serve as an additional tool for community health workers and primary healthcare staff. And in addition, Mamás de la Frontera Newborn Layette, that is distributed by community health workers to the newborns, now includes a baby's first toothbrush and fluoride toothpaste. But evidence suggests that education alone is not enough. The Mamás del Río process evaluation showed that meaningful change did not depend on information alone, but on multiple pathways, including practical materials, the supervision, the community support, and facilitation of access to care. And the WHO implementation manual on ending early childhood caries is fully consistent with this message that education matters, but effective prevention requires supporting environments and broader integration with services. And the point is not just to inform the families, but to create the conditions that make prevention possible. So my global fellowship starts from that gap that oral health has already been introduced into Mamás de la Frontera, but introducing messages is not the same as achieving sustained adoption, and especially in that context of poverty and isolation. So the next step is to return to indigenous Amazonian communities to understand what makes essential early childhood caries preventive practices feasible or not in everyday life. My fellowship project is designed as a formative study to inform future implementation, and its goal is to explore barriers and facilitators related to 4 essential early childhood caries prevention practices, not only at the level of individual knowledge or behavior, but across the multiple levels that shape whether prevention is actually feasible. It is meant to generate the evidence needed before designing a stronger community-based intervention. And the study will examine barriers and facilitators across socio-ecological levels, the individual, interpersonal, community, and structural levels, because prevention depends not only on knowledge, but also on family dynamics, the community actors, the services, the resources, and the broader territorial conditions. And methodologically, this will be done through qualitative work, mainly in-depth interviews and focus groups, in order to understand how these practices are perceived, supported, or constrained to made possible in real life, and how to understand how policy, services, and community can be articulated. And the second major component of the project is to translate the qualitative findings into a brief community diagnostic tool. And the idea is not to create a large survey, but a practical tool that can help identify local barriers, facilitators, available supports, missing resources, and feasible actions for early childhood caries prevention that can be also adapted for use in other contexts. And this tool will be tested first for comprehension and then piloted in real-world use. Ultimately, the purpose of the fellowship is not only to understand the problem better, but to leave behind something useful and a more context-sensitive basis for implementation and a stronger foundation for a future intervention. Well, finally, I want to leave a take-home message. Well, let's ask ourselves what is truly needed to improve oral health. It's more traditional dentistry. Well, dentistry has a central role, but to make a real difference, dentistry must move beyond isolated procedures center care and become part of prevention-oriented, interprofessional, intersectoral, and community-based action. And clinical procedures are necessary, but they are not enough, and they must be complemented by education, collaboration, and collective action that reach people where they live, learn, work, and grow. And only then can oral health become part of the broader commitment to better life for all and leaving no one behind. Thank you very much for your attention. Muchas gracias.
Thank you so much for sharing those thoughts, and the images just were really striking and brought us right there, so we can envision what it's a little bit of what it's like to work and live in these communities. We've got some time for questions and comments. I'll take a few from the Q&A. Before we get too wrapped up in that, I'm going to post to the chat. We have a survey just for a quick evaluation, some thoughts, some feedbacks on the symposium today. I encourage anyone from the audience to click and take a look. And if you have suggestions for speakers or themes and topics to consider in future symposia, please share with us there. But we're not done yet. Don't leave. Ximena, I've got just one overall question, thinking about the context of where you're working. What kind of preventive care measures for early childhood caries are present in the Amazon region of Peru right now? What do families realistically have access to, and what's lacking? I saw some dentists on your slides. How regularly are they reaching communities? What resources are there? And what would you like to see appear when it comes to oral health?
Yeah, there is a major hospital in the area, but it's not easy to access to the health centers because the communities, these are very remote. They have to travel a lot of hours, maybe days, to reach the hospital. So it's not easy, and it's also cost a lot of money for them. That's the case because they didn't go usually to the health services. And for example, pregnant women prefer to have births in home. And other problem is that they are not connected. The health center or the health personnel are not connected with the community, so they didn't feel comfortable to go to the hospitals or health centers. That's a major problem. About the measures that I mentioned, I read in one of the questions about the water fluoridation. It's not some realistic in that area, and also in Peru, because there are a lot of areas that not have secure water, running water, so it can't reach everyone. But we have, I think that the most effective measure is toothpaste, fluoride toothpaste. And in my travels, I found a really big problem about the toothpaste, because we know about the evidence that we need at least 1,000 parts per million of fluoride. And maybe for a risk population, especially. This is a risk population, a high risk population, and the toothpaste that they can afford by the health center or social programs is only with 500 parts per million. That are toothpastes that are not commercialized in the big cities because people have more information and they don't buy them. So all that toothpastes are sending to the remote places. And the alarming thing is that the Ministry of Health is allowing that toothpastes are given in the services and also in the social programs. We are with the community health workers. We want to share this information with all the families, because they can use the family toothpaste and to do the education about the quantity and the importance, because we know that the most important measure is to not exposure to sugar, but they are a high-risk population, and we need the other part to contrast that is the fluoride.
Another question came in about fluoride. So you mentioned water fluoridation not being realistic in a lot of these communities, and some of the advantages and challenges with fluoride toothpaste. Is salt fluoridation something that's available in Peru or common?
Yes, in Peru there is salt fluoridation, but there is no monitoring about that. There are some research that show that it's below the minimum level that we need.
Another question here, thinking about implementation science. So what do you think about the sustainability and scalability of having an oral health component to a program like Mamas de la Frontera? So once it's created, how do you see this continuing on and having impact beyond, a one-year project? How can you make it sustainable and scalable and reach more people?
It's very important to think in that, and that implementation would have more time to working. And the major program, the broader program, have a lot of connections to make the program still running. So that's because I choose that platform, because I have the project to do that integration, but when I applied to the FDI, I found, but I didn't have the specific population I was looking for, and I found that this was perfect because it was my my target, the pregnant women and the first 1,000 days of life. And also the director of that program, that platform, is now part of a lot of political issues in Peru. So I think that she became part of all of that because she saw that she begin to have a lot of evidence, but only they can go beyond their program, and she wants to all that good results go to all the country. So now she's in part of some political important issues in Peru. So I think that it's also very important. She is like fighting to pass a law for the recognition of the community health workers in all the country, because the community health workers in Peru are volunteers now, and they don't have recognition. We want them to be part of all the health system.
So one last thought, I think this applies to both the presentation today. So maybe Ximena and Carol may both have some thoughts on this. All the communities we talked about today face some really serious challenges. And so you think about, their priorities when they're dealing with conflict and violence and crime, or just living in a very remote community where it's challenging to find opportunities for education and employment and healthcare. Oral health may or may not be something that ever rises to the very top of their concerns in that context. But what do you hear from the communities in terms of the value of oral health and what it means to them?
Should I go ahead?
Yeah, please.
Well, definitely most of the time it's not really the first thing that comes when you identify priorities. Your struggle with keeping yourself alive or bringing bread to the table, probably oral health issues are not really up there. But then when you start chatting about how that basic stuff is definitely related to health and oral health, and how oral health is related to communication, feelings, expressions, the way you eat, sleep, I mean, all the functions related to oral health. Then you start a dialogue that then brings oral health narratives to life. And then, for example, a very nice experience with older adults was when they told us their life course stories about oral health struggles starting very early in their lives. So you need, I guess, to dig a little bit. You need to go through the probably more relevant struggles first. But as time passes, as you gain trust and you start chatting, listening about their lives, their experiences, then oral health will come. And of course, it's an interesting exercise to make it link with everything else. It's not isolated. It has to do with poverty, it has to do with, violence, it has to do with living in a remote area. So that dialogue then starts to build up with communities and is beautiful. But yeah, it might not come as the first thing. Yeah, most of the time. Yeah, thank you, Ben.
Well, in my case, I saw a really difficult and challenging context when I traveled to the Peruvian Amazonian area. And I want to understand more in depth all the context. So I went there to live for between 2024 and 2025. I lived almost a year there, working in one public health center. I saw a lot of things very, very alarming. I see a lot of teenagers that was kidnapped, and I was very shocking. But the people told me, but this is that's something that happen every day. Like Carol said, or maybe oral health is not a priority. They have a lot of other priorities and problems, very major problems. But to think about all the promotion that really means promotion, health promotion, that to make people to understand that they can control their health by ourselves is the most important, and to show them that they can do with some measures that are very simple, that you don't have to have money to do that, but they need the collaboration, they need the engagement and the environmental that facilitate to do that things. And I think that if we do more intervention that are supporting by all of the sociological levels, we can have an intervention that can be really, really feasible.
Well, thank you. Thank you both of you for the work that you do, for sharing it with us today. Wonderful presentations. It was so much fun to spend some time with you. We're at the time today. I want to say also thank you to John Test, who's been quietly in the background, making sure none of this programming crashes on us. Fantastic support from UCSF Technology Services. Thank you to everybody who joined us today for your comments, your questions, and have a wonderful and healthy time out there. Thanks for joining us, and we'll catch you next time.
Thank you. Bye, everyone.
Bye, thanks.